Lovely. Okay, guys, we're going to get started because I'm conscious of time, and I'm conscious of giving Qasim some sort of a Monday evening to relax. Firstly, thanks so much, Qasim, for joining us on a dark, cold January evening to talk about rheumatology and ultrasound. I'm very grateful for your time, expertise, and certainly your enthusiasm as well for the topic, and providing this hopefully a really useful CPD event for everybody this evening. So what I'm going to do is hand over to you to sort of formally introduce yourself, and I will take away my spotlight, as it's called, and that will leave you to take the stage. So all over to you.
Okay, fine. I'm going to stop my video and crack on with the talk. Okay, so good evening, everyone. So my name's Dr. Qasim Akram. I'm based in Manchester, Greater Manchester. I work at Stockport NHS Foundation Trust, and I'm going to talk to you about the role of ultrasound in rheumatology. So a little bit about me. I am a ULAR level 2 ultrasound instructor. What this means is that as a rheumatologist, I've got probably one of the highest sort of accreditations in ultrasound. It means that I can actively do ultrasound scans. I've been assessed and certified, but also can organize courses and things like that. And it's quite a rigorous training program. Part of my training, I actually did an ultrasound fellowship in a center of excellence with a Professor Noredo in Spain, and she was a real pioneer of ultrasound in rheumatology and has been working in this field for, you know, the best part of 20 to 25 years, and has really led kind of a revolution of rheumatologists scanning at the point of care. So following all that experience, I now, in my consultant post, I lead what we call the Stockport Early Inflammatory Arthritis One-Stop Shop Clinic, where anyone who has a diagnosis of early inflammatory arthritis is seen fairly quickly by us. But on the actual clinic assessment, they also get an ultrasound scan as well. So they get a diagnosis on the same day. I also lead the Stockport GCA fast track pathway. So this is patients that have giant cell arthritis, and we try to see them fairly quickly with an ultrasound scan, usually within a couple of days as well. I also lead on this, and I also lead on a fellowship program for our specialty trainees. So, you know, the next generation of rheumatologists all have some aptitude for ultrasound. Okay, so a little bit about ultrasound, and you know, this talk is mainly looking at the basics of rheumatology ultrasound, and you know, we won't cover everything, but it's just to give you guys a little bit of a flavor, and you know, we can obviously do a Q&A at the end where I'll be available for any sort of questions. So why ultrasound? Well, we know ultrasound is great, it's safe, it's reliable, it's cheap, well tolerated, it can be performed at the bedside, and it's also really, really good for patients to understand the disease. So this is not just in rheumatology, it's good in lots of other modalities, but specifically to rheumatology, I do find that these are some really useful things. The disadvantages are obviously it's operator dependent and requires quite a lot of expertise. So general principles for rheumatology that, you know, apply to other areas of MSK ultrasound are that, you know, you probably need to use a high frequency transducer, especially when we're assessing the peripheral joints. That is usually the bread and butter of our work. Hands, feet. We tend to look at other joints as well, but less commonly so. We try to get the best possible image, and we want to confirm that into perpendicular planes, both transverse and longitudinal, especially if there is any pathology. I also recommend using lots of gel to really optimize the images. So these are the different conditions that ultrasound, plays a really important role in rheumatology. So on the left-hand side, you can see rheumatoid arthritis, which is part of a condition called inflammatory arthritis. Within that, we also have spondyloarthropathy and psoriatic arthritis. And then we move down to things like gout, pseudo-gout, osteoarthritis, and other things like SLE, Sjogren's syndrome, and giant cell arthritis. So in rheumatoid arthritis, we see something called synovitis on ultrasound, and this is usually one of the classical appearances of any sort of active disease. We can also see joint effusions. Sometimes we may see erosions, especially in very aggressive type of disease. Now, one of the other earliest forms of disease presentation can be with the detection of tenosynovitis. So you may see this in some of the cases that you're scanning in your practice. If we look at psoriatic arthritis, again, it's very, very similar. You can have synovitis, you can have effusions, you can have erosion, but we tend to get a few other things that are probably less common in rheumatoid arthritis. We get something called enthesitis, and I'll talk about that in a bit more detail later on. This is essentially when we get inflammation at the site of the insertion into the bone, the insertion of the muscle into the bone, and it's usually the tendon which tends to be inflamed as well. And this is usually quite classic, and there's several different areas that this can commonly affect, such as the Achilles tendon, but also things like the lateral and medial epicondyles, etc. Now, with gout, gout is not an inflammatory arthritis, but gout can look like an inflammatory arthritis. So patients can present with swelling of joints, and it can resemble it can resemble rheumatoid, it can resemble psoriatic arthritis as well, but the ultrasound appearances are usually very different. You can normally see gouty tophi, so gout tends to be a collection of crystals, and we usually see the deposition of crystals within the joint. And again, I will show you some pictures later on of this. We can also see effusions, we can also see erosions, which are usually quite different to the erosions that we see in rheumatoid arthritis. Now, one of the other features of gout is what we call the double contour sign. This is usually quite pathognomonic as well, and I'll show images of this later on. Pseudo-gout, again, is similar to gout. It's just a different crystal which forms within the joints. Again, it can cause effusions, but slightly different to gout. You can get the crystal deposition, usually deposited within the cartilage, whereas with gout, you tend to get it on the surface of the cartilage. So osteoarthritis is a degenerative condition. So again, it can sometimes resemble an inflammatory arthritis, and we get quite a lot of patients who come to our clinic with a presentation of osteoarthritis where the GP may say, look, this person's got swollen joints. Usually they're quite bony, they're quite hard, but they can't differentiate whether it's rheumatoid or not. So we tend to see them as well, and we see some classical changes of osteoarthritis, such as osteophytes, and I'll show you these images later on. Osteoarthritis can also cause effusions, and less commonly it can cause some synovitis, but usually there's a distinct form of osteoarthritis that's present usually in those cases. So SLE is again the same. We don't tend to see a lot of this within the clinic, but again, it can have similar changes as rheumatoid arthritis, such as synovitis and effusions. The other ways that we tend to use ultrasound, it's not just musculoskeletal disease, and I prefer to call it rheumatology ultrasound. And that's because we actually look at salivary glands in a condition called Sjogren's syndrome. Sjogren's syndrome is a condition where you have autoimmune destruction of the exocrine glands, and typically it can affect the salivary glands. And we see these classic changes when we do ultrasound. And finally, there's a condition called giant cell arthritis, which many of you will know about, some of you may not do. This is when you tend to get inflammation of the blood vessels. It's a vasculitis, usually affects elderly people. And if we don't treat it and if we don't detect it, people can become blind very quickly. So it's really, really important. Over the last few years, ultrasound has shown that it can actually detect the classic changes of this, hence more and more rheumatology departments up and down the country are starting to use this as a diagnostic tool, and usually you can, try and get someone in for a scan within a day or so. So, and again, I'll show some of these classic changes later on. Okay, so in terms of, if we now look at the individual sort of diseases, and I've grouped this into inflammatory arthritis. So this is your rheumatoid, this is your psoriatic arthritis. Now, what the whole thing about ultrasound is that it's seen as an extension to clinical examination. So, as rheumatologists, we don't forget the fact that we are rheumatologists. We rely on our history taking, we rely on our examination, but also ultrasound is akin to a cardiologist's stethoscope, where it helps us within our kind of assessment of patient. We know that ultrasound is it's not so helpful in people who've got what we call barn door disease. So sometimes if someone presents and they've got good going swelling of the joints, their history is very typical for rheumatoid arthritis, their blood tests, their laboratory abnormalities are all there, then I'll be less inclined to do an ultrasound scan because I know what the diagnosis is. However, it's useful in patients where they have symptoms, but you can't really see anything on examination. This is what we call subclinical disease. And what ultrasound does is it can detect the earlier signs of inflammation or stages of inflammation, meaning that we can pick up these patients a lot sooner. That's why we have what we call one-stop shop or early inflammatory arthritis clinics, because we know that if we detect these patients early, we can actually treat them and we could potentially reverse their disease outcomes. And everyone's seen those patients with rheumatoid arthritis with terrible looking deformities of their hands. But now with both early detection and better treatments, we don't tend to see this as well. We also know that ultrasound is helpful in being able to distinguish all the different pathologies that I've talked about previously. So we've talked about rheumatoid arthritis, psoriatic arthritis, and sometimes even to rheumatologists, it's not clear. Once you've taken the history, once you've examined, you don't know whether it's psoriatic arthritis, is it rheumatoid. So ultrasound is really, really helpful. So for me, it's just about gaining as much information as possible, and mainly at the bedside. It doesn't obviously have the same costs as MRI, and it gives different images. So now moving on to what we actually see on ultrasound within the inflammatory arthritis, we talk about synovial hypertrophy, and this is where you have swelling of the actual synovium, which is a hallmark of the actual disease. But on ultrasound, we'll tend to see this as a hypoechoic area, which is usually non-displaceable and it's poorly compressed. So that's usually the rules for calling something synovial hypertrophy. Sometimes with synovial hypertrophy, you may have what we call Doppler activity. So that is blood flow that can indicate ongoing inflammatory activity. Just because you don't have hyperemia doesn't mean that, you know, this patient doesn't have any disease. It may just well be that on that day that you're scanning, they don't actually have any activity, but previously they may have had that, and this can be shown up in synovial hypertrophy. Now, effusions are usually black, anechoic areas, they're usually very compressible, displaceable, and there's usually no Doppler signal. So that's the contrast between synovial hypertrophy. Effusions are also useful because if you're not sure about the diagnosis and you see an effusion, it's usually quite a juicy area of fluid that you can pop a needle into and maybe have a look for any synovial analysis as well. So this is an example of a normal wrist joint. This is the radiocarpal joint, which you can see on the right-hand side. You know, you've got the distal end of the radius, you've got the lunate, and then you've got the capitate. And this is, you know, this is fairly normal. If you look at the synovial synovium, you don't really see any hypertrophy, and it looks fairly okay. The bones look okay as well. And, you know, if we look at the tendon over the top, there isn't any evidence of any tenosynovitis. So whenever I'm scanning, I'm just trying to look for lots of different things. I'm looking for as much information as I possibly can. Now, here is some synovitis on the left-hand side, the left image. You've got some synovial hypertrophy of the wrist, which I'm sure you can all identify. You know, if I saw this, I would try to compress it, see if I could compress it. I'd try and move it and see if it was movable. On the other side, you can see some Doppler activity as well, suggesting that this is active synovitis. Now, that was the wrist joint. If we move on to the MCP and the PIP and the MTP joints, this is usually what we tend to see in these joints. These are the smaller joints, which are commonly affected by inflammatory arthritis. So rheumatologists, we spend a lot of time looking at these individual joints. So in my EIA clinic, I will spend a lot of time going through all the different joints. You can see here that, you know, all these images look okay, and there isn't any evidence of any significant synovial hypertrophy. However, if we look at this image, this is some synovitis of the MCP joint. This is one of my patients who had an inflammatory arthritis, and the image on the right-hand side shows that there is some Doppler activity. And the same here as well with the PIPJ. You've got some inflammation here as well with some Doppler activity. Now, an important point here really is that if we actually just, you know, say it's synovial hypertrophy or synovitis, I mean, it's helpful, but I think it's more helpful to actually grade it. And a trend amongst a lot of rheumatologists is to maybe you know, put this in reports as well, because it can really help rheumatologists make treatment decisions, especially if they're receiving a report and they don't scan themselves, and if you're scanning as well. So if we go through this, and I'll show some pictures afterwards, which will, you know, make this a bit clearer. Grade 0 is usually when we don't have any thickening of the synovium. Grade 1 is usually when we get a little bit of thickening, and grade 2 is when we get thickening and bulging over the line, which usually links the top of the periarticular bones. And grade 3 is usually when we get some synovial thickening and bulging, but also extension across the periarticular lines. If we think about grade 0 and grade 1, usually if a rheumatologist looks at that report, or if you put that in a report, they'll look at it and say, well, that's not that significant. We get a bit more excited with grade 2 and grade 3. Now, the same with Doppler as well. We look at, you know, how many blood vessels there are. If we've got no flow, that's a grade 0. If there's a single vessel, again, that suggests that there is something, but it could be anything. It may even be an artifact. However, if there is less than half of the area of the synovium is covered by blood vessels, then that is a grade 2. And grade 3.
Sorry, Qasim. I'm just going to check through. Can everyone just keep themselves on mute if possible? I think somebody's not on mute.
Suggest why a single HbA1c test cannot indicate.
Can we see who that is?
Yeah, I'm just gonna. I think I can do it here. Okay, I think it's sorted. Carry on. Sorry.
No problem. No problem. Right. Okay. So, and then grade 3 is usually when we get vessel signal in more than half of the area of the synovium. So, if you tell someone that there's grade 2 or grade 3, then they have an idea that yes, there's definitely some good going inflammation here. So here, is a nice image, really, comparing the different gradings. If we look at the left-hand side, you've got all the different grades. You've got some nice diagrams as well. We've got grade 0, grade 1, grade 2, grade 3 as well. And this is something that I want you to maybe look at in your own time when the slides are shared, really, and it gives you a nice idea of the different grading. So, I mean, normally grade 2 for both synovial hypertrophy and grade 2 for Doppler is usually more indicative of significant disease. And I think it's really helpful because I have colleagues, rheumatology colleagues, that don't scan, and sometimes they'll receive reports either in the NHS or in the private sector, and they always bring them to me and say, well, what does this mean? And I think some of our radiologists have actually adopted this just to try and help them make treatment decisions. So this is the knee fusion. I think that's Stuart on the left-hand side. Actually, it's one of your images, Stu. And this is. I think
it's my knee, my athletic.
Yeah. Is it your knee? Yeah, yeah. So this is a suprapatellar effusion. This is just an example to show you what an effusion looks like. This is anechoic. We know it's very dark, it's very black. Take my word for it, it was very compressible and movable as well. If we look at, again, these are images really to show you, this is the tibio-talar joint, again, a common joint that's affected in inflammatory arthritis. And here you can see some synovial hypertrophy as well. Here you've got some synovitis with maybe a bit of Doppler activity, and actually looking at that, I'm not fully convinced. Actually, it's probably more artifact than actual Doppler signal within the joint. But there is a significant Graysdale synovial hypertrophy here, and I'd probably label this as a grade 3. This again is looking at the first MTPJ, and an important point about the MTPJ, the first MTPJ, and in fact quite a lot of the MTPJs, is that they actually do usually display a grade 1 or even a grade 2 synovial hypertrophy because of the stresses that are usually put on the feet when everyone's walking. The people have different body weights as well. All that sort of weight goes through, and you can have different levels. What is abnormal in these cases is if we have any Doppler activity. So having a bit of synovial hypertrophy, I think, is normal, but if you have some Doppler activity, that's not normal. So we've talked about synovial hypertrophy, we talked about synovitis, then we can also move on to tenosynovitis. This is usually when we have some inflammation around the flexor and extensor tendons. Normally, this is usually described as a hypoechoic or anechoic thickened tissue within the actual tendon sheath, and sometimes we can have some Doppler activity. There are a couple of places that are common in rheumatological disease. If we think about rheumatoid arthritis, you tend to get involvement of the extensor carpi ulnaris in the wrist, which is the sixth extensor tendon compartment, usually can indicate erosive disease and early disease. You can also get involvement of the flexor pollicis longus as well. So these are areas that you really want to look at if you are suspicious. There is something called peritendinitis, which tends to affect more the spondyloarthropathies, and PSA normally affects the extensor digitorum tendons, usually at the level of the MCPJ and beyond, but also the Achilles tendon as well. This is again an example of florid tenosynovitis of the fourth extensor tendon, and you can see that this is confirmed in both short axes and long axes, and we've also got some intense Doppler activity as well. Here is an example of an ECU tenosynovitis, both in short axes but also long axes as well. You can see the hyperechoic area, which is above and below the tendon, which is confirmed on 2 planes as well. Here, we're looking at the index finger flexor tenosynovitis, both in grayscale, but also some power Doppler as well. I can't see much power Doppler activity, but you can actually see this hyperechoic area in both long and short axes. Here we've got an inflamed flexor tendon. Again, I think this is a patient with rheumatoid arthritis. So you can see that as well as looking at the joints, we really have a good and detailed look at the flexor tendons as well. And there's definitely some Doppler activity around the actual tendon on the short axis. Usually when it's quite dramatic, you can actually see what we call a ring of fire all the way around. In fact, here we go. This is an extensor tendon tendonitis in probably a patient with PSA, and again you've got this intense Doppler activity. Here is an example of a tibialis posterior tenosynovitis. Again, it's a common region that is affected, as well as the peroneal tendons, which you can see here. So this is really to give you a bit of a flavor of what sort of things that we see in inflammatory diseases. Now, we've talked about tenosynovitis, we've talked about synovitis. Now I'm moving on to bony erosions. Usually this is indicative of aggressive disease, but also long-term disease, chronic disease. Normally this is usually seen in bony, two different planes. Normally there's a break in the bony surface. The way to have a look at these, I mean, rheumatoid arthritis usually looks slightly different to, say, gout, but also PSA as well. Usually PSA tends to be where the emphasis is, or when the enthesitis is, that's where you'll get an erosion, whereas rheumatoid arthritis is usually within the joint. Gout is usually outside the joint. And one of the other things about ultrasound is it's so sensitive at picking these up a lot quicker than X-ray. So here you've got an example of an ulnar styloid with a nice big erosion with a big step. Here you've got an example of an MCPJ in a patient with rheumatoid who's got a significant erosion. So on the left-hand side, you've got it in short axes. On the right-hand side, it's in long axes on the left, short axes on the right. Here is an example of someone with an erosion, but with some powered Doppler activity. Normally, if there is some powered Doppler activity within the actual erosion, that indicates that, you know, it's a fresh erosion, it's an ongoing erosion. Again, it kind of tells me that this person has got really aggressive disease, and then I can think about what sort of treatment I want to put them on. And this is an example of a first MTPJ erosion. Okay, now, psoriatic arthritis and spondyloarthropathies are slightly different to rheumatoid arthritis, where you tend to get less involvement within the joint, more involvement of the tendons. You tend to get more of an intense Doppler signal as well. You can get it at enthesitis or entheses, usually at the Achilles tendons, plantar fascias, medial lateral epicondyle. So if you're seeing inflammation there, usually it tells you that it's probably more of an SPA type problem. We can also have something called dactylitis, where you get this typical sausage digit, and that sausage digit actually comprises tenosynovitis of the flexor tendons, but also tenosynovitis of the extensor tendon, and also quite a lot of swelling within the joint with some intense Doppler activity and kind of swelling of the subcutaneous tissue as well. So it's kind of a pan digit sort of swelling. We can also have other things like erosions, calcifications, and enthesophytes, but Doppler is really important, because if you've got Doppler activity, you can usually differentiate that from more mechanical type causes, because we know that people can have mechanical enthesophytes and calcifications as well. So this is an example of a normal Achilles tendon on the left-hand side, and on the right-hand side, you've got an abnormal Achilles tendon. You've got different stars here, and what you can actually see if we look at the actual tendon is that we've got some Doppler activity within the actual tendon. That usually indicates that there is some ongoing tendinitis. We've also got some inflammation around the retrocalcaneal bursa as well. Again, this is usually commonly seen in inflammatory arthritis, and also there is some inflammation at the insertion of the Achilles tendon, and you can actually see some Doppler activity there as well. This again is an example of someone with a large retrocalcaneal bursa with the star, and E indicates these steps and these enthesophytes here, which are probably likely due to some form of spondyloarthropathy. This is one of my patients who's actually doing quite well now, but this was one of her initial scans of the Achilles tendon, and you can actually see there's so much pathology here. You've got some intense Doppler activity within the actual tendon, you've got calcifications within the tendon, and you've actually got enthesitis as well at the insertion site. And that's something that's confirmed on both short and long axes. So moving on to osteoarthritis, normally you don't tend to get synovitis unless you get a condition called inflammatory osteoarthritis, which is, it can happen, but you don't see it as commonly. But you tend to get these characteristic bony spurs, which are usually next to the joint space. And normally if someone says, look, I've been having problems within my joints, this swelling up, normally this is quite satisfying when you actually scan them and you can actually see these changes, because you can tell them, although there's not a lot of treatment for osteoarthritis, you can tell them that it's not a rheumatoid arthritis. So here you've got an example. So in the middle images, the middle ultrasound images, or the ultrasound images on the left-hand side, that's their normal joints. But on the other side, on the right-hand side, you can see the difference. And these are osteoarthritis patients, and you can, see these bony spurs here. You've got these bony spurs as well. Sometimes you can have a little bit of fluid around them as well. If you have, you should always look for Doppler activity as well. Just make sure there's no Doppler in there as well. Now, moving on to gout, I previously mentioned that gout is when you get a collection of crystals that are forming. Normally, it's typically caused by people who may be drinking a lot of alcohol, eating lots of red meat, drinking lots of fizzy drinks, not getting enough hydration, etc. And you can kind of get these dense deposits of gouty crystals within the joints. Sometimes when they do form, they're called tophi, but they can actually cause other things as well. There's something called the double contour sign as well. Normally it's usually on the articular surface of the cartilage, so it gives this nice sort of double contour appearance, and I'll show an image of that in a second. You can also get some erosions. Usually they're different to the ones that we see in rheumatoid and psoriatic arthritis. Common sites are usually the first MTPJ. That's usually a really, really classic place for gout. It's something that we call podagra, but you can get it in places like the knee, elbows as well. So if you have someone like this, it's really, really important to have a look at these areas to try and find out whether you can actually see a double contour sign. And it's usually quite satisfying. It's also quite good when you actually give them treatment and you can follow these patients up, and you can see an improvement in the gouty crystal. So this is an example of an MCPJ at the top, and you can actually see this deposit of gout crystals over the top of the hyaline cartilage, which kind of gives that trom-line appearance. Here you've got a knee joint, and this is the knee joint in a transverse view, and you can actually see the femoral cartilage where you've actually got this tram-line appearance as well. This is an example of some gouty tophi, both in the MCPJ on this side, on the left-hand side, the PIPJ on the right-hand side. Again, you can kind of see it's like a sugar clump type appearance that you see. Again, it's really satisfying when you can see this. You can also have this in other unusual places like tendons as well, and some of the images below show that. But again, this is usually less common. Normally it occurs in and around the joints. I previously mentioned a condition called pseudogout, and pseudogout is something that resembles gout but isn't gout. The main reason it isn't gout is that the crystal is different. It's a calcium pyrophosphate crystal, whereas gout is monosodium urate. Now, the difference with this condition is that, I mean, it's important to identify these two different conditions because they have different treatments, but normally you actually get deposition of the crystal within the actual cartilage rather than on the surface like gout. Also, you have different sites that are usually affected. The wrist triangular fibrocartilage is a really common place for this actually. So if you see crystals there, if you see some calcifications, you know that this is pseudogout. And I'd also recommend doing x-rays, plain film x-rays, so you can get that comparison, because it normally shows up quite well on plain film x-rays. Now, lastly, I'm going to talk about giant cell arthritis or large vessel vasculitis, and we previously talked about this condition. It's a really serious condition. It can cause irreversible sight loss, so we need to really try and diagnose it and pick it up as soon as possible. Previously, the only way to diagnose this condition was through history examination, blood tests, but we would do what we call a temporal artery biopsy, where we would take a chunk of the temporal artery and then have a look under the microscope. Now, one of the main issues with this was that it's an invasive procedure. It's normally done in a theatre setting. It can only be done by usually ophthalmologists, but also max fac surgeons, etc. And it just meant that it was quite tricky to get these people into a theatre slot, etc., etc. At the same time, the sensitivity and the specificity was not fantastic either, because the way GCA is that it actually affects the artery in skip lesions. So if you sample a part of the artery that's not diseased, which can happen, you may not actually see the actual condition. So it can influence your potential management. Now, over the last few years, ultrasound has really emerged as a really good diagnostic modality for GCA, where it can actually detect quite a large area of arteries. So we actually do quite a detailed examination where we look at lots of different aspects of the temporal artery, and it gives us a really good idea of whether there's any inflammation or not. The studies at the moment show that it probably performs as well as temporal artery biopsy. So it's kind of moved to the point where it's actually recommended that it should be the first line investigation in giant cell arthritis. And these are European and national guidelines. So there's a real push on rheumatology departments up and down the country to have what we call the fast track pathway, where there is a setup for ultrasound. So as soon as these patients present, we can get them in for an ultrasound as soon as possible, and then decide on treatments. The treatment for GCA is usually steroids as well. So steroids can actually affect, if you put someone on steroids, it can affect the results of biopsy, but also ultrasound as well. So even though we don't say that you shouldn't treat patients, because if there's a potential risk of losing sight, we do recommend that patients are treated as soon as possible, but we want them to be to have an ultrasound scan as soon as possible, usually within 24 to 48 hours. Any longer, the changes can go away as well. So these are some of the characteristic changes that you tend to see with GCA. And the image at the top is so that's image A. Is a temporal artery in a short axis view, and that corresponds to the picture on the left hand side. Here you've got this halo sign over the artery, and this is vessel wall edema, which is indicative of some sort of inflammatory process. Again, we don't rely just on one image, we rely on a transverse image, and that's the image that you can see in B, sorry, the long axis image, which you can see in B. Now C shows someone with established disease who has got occlusion of the blood vessel, and D shows what we call intima media thickness, and normally what we tend to do is measure the internal wall of the blood vessel to see if there's been any thickening or not. And we usually have these cutoffs. So if it's usually above a cutoff, it indicates that there has been some sort of inflammation or some sort of insult to that vessel wall. And I'm not saying it's always GCA, because there could be a few other things as well, but it's important to think about GCA as a potential cause as well. Okay, so I think that is the end of my talk. So that's 44 slides and 44 minutes.
Great, thanks, Qasim. I'm gonna just do a bit of rejigging here. Boom, boom, boom. So if we do that, that's fine. So if you want to stop your sharing, I think I can do it actually. There we go.
Yeah, that's
cool. And I will just pin you as well. So hopefully everybody can see both of us. Not that that's necessarily a particularly positive thing, but hopefully everybody can see us. Thanks so much, Qasim. That was brilliant. Really enjoyed that. I've certainly got a few questions. There's a couple of questions I think on the chat as well, guys. If you've got questions, please don't be shy. This is meant to be very informal, useful, positive, educational kind of situation. Though both of us certainly, very happy to take any sorts of questions. We've got about 15 minutes. I'm going to try and wrap up at about 9 o'clock. The first question was from Steve Wells, podiatrist, somebody I know very well. Great question about, you mentioned about hyperemia, I think particularly with regards to PSA and looking at the enthesis and the plantar fascia. He's asked, how easy is it to see hyperemia around the plantar fascia enthesis with those psoriatic arthritis patients?
Yeah, that's a really good question, Steve. The honest answer is it's quite difficult. The plantar fascia is a really tricky area, actually. I think it's much easier to look at the Achilles tendon and look for inflammation there. I suppose the only thing with the plantar fascia with PSA, I suppose, would be sort of thickening. So even though that, the textbooks would say that, you could potentially see that, I've rarely seen it. So yeah, thickening is something that I would probably say is more indicative of, an SPA type presentation. But, Achilles tendonitis is usually pretty sensitive.
And I guess with all of these things, the challenge that we have, isn't it, from the clinician's perspective, is to say what is a mechanical, normal plantar fasciopathy, or what is a normal insertional or mechanical insertional Achilles tendinopathy. And are there any particular features, do you think, that help sort of give you that weight around the sort of the PSA side of things? Other questions you might ask?
Yeah, I mean, I suppose, I think Doppler is usually, pretty, it can, usually differentiate between, a mechanical cause and an inflammatory cause. We usually have the benefit of a history and examination as well, and other laboratory tests as well. So, I think, I always say this about ultrasound as well. You can't just rely on ultrasound to tell you if it's, mechanical. If I use it as part of my examination. But it's not, it's not the complete. And sometimes there are so many gray areas there. But I think if I see inflammation, sort of Doppler activity, usually at the site of the enthesis or enthesitis, if there's an erosion near the enthesis as well, I'd probably think that this is more of an inflammatory, rather than a mechanical type problem.
Yeah, brilliant. That's a really important point, isn't it? We're talking here about it. We're using ultrasound in the clinical context, being very aware of the overall kind of patient narrative, as opposed to maybe more isolated for the diagnostics.
Yeah, and I suppose the other thing as well is that I know that quite a lot of podiatrists, quite a lot of physios use it, in different settings as well. And I suppose you're not really there to diagnose, but
I think we're losing you a little bit.
Idea.
Hopefully he'll come back.
Hello. Yep. You can't see me? Yeah, perfect. Hi, Stuart. Can you hear me? Stuart, I think you're muted.
Okay, I'm back. Did you lose? Did everyone else get cut off? Was it just me?
I think it was just you.
There we go. I think I've got a few of the chat. I've lost the chat questions as well. Brilliant. The last time that happened was during a thunderstorm in August, so that was really good to happen again. Anyway, you can hear me all right, can you now?
Yes, yeah.
Perfect. Okay. I think the other question that was on the chat. Sorry, guys. I think you might have to re-add your questions back onto the chat again. Sorry. Was around, do you follow a particular protocol when you're evaluating kind of small joints of the hands, or do you just focus on the ones that patients particularly say are symptomatic?
To be honest with you, I mean, we've got quite specific protocols to follow in rheumatology, and I was explaining before that we tend to look at quite a lot of the joint area as well. So we pretty much kind of, start on, if we're looking at the hands, it's usually, dorsal aspect, look at the radiocarpal joints, have a look at the extensor tendons, have a look at the sides as well, the ulnar styloid, look at the other side as well, look for any erosions, look for any kind of synovitis, and then start to move down to the individual MCP, PIP, DIPJ. So it's quite onerous because we are looking at quite a lot of the different joints, but I think over time you practice and you get sort of an idea. Then at the same time, I'll flip the hand over, have a look at the flexor tendons, kind of a gross look at the flexor tendons. Then I tend to look at the flexor pollicis longus, and then have a look at the wrist joint as well, at the level of the flexor tendons and the carpal tunnel, etc. So that's usually my kind of examination, of the hand. And I think over time I've kind of got it down to, it depends. I mean, sometimes if you've got someone who has, it's a normal kind of scan, it's fairly straightforward, isn't it? You can scan fairly quickly. But if someone's got a pathology, then it can take a bit more time because if there's an erosion, you've got to look in two different planes, etc., etc.
From a rheumatologist point of view, I know you talked about grading. Is it important from a rheumatologist point of view that that there's every single joint that's got synovitis in it, or are you interested in just the fact that there is synovitis in, I don't know, 2 or 3 joints, and it's active synovitis? Do you need to know the grading?
Yeah, so I think, that's a really good question, actually. I think we need to know whether there is some synovitis. So the only reason for scanning all the different joints is to see if we can see any erosions. The reason for that is that if we see erosions, then it usually, I can have a phenotype of a patient, a specific phenotype, and say, well, this person has got erosive disease. So that means that I can target my treatment, to be a bit more aggressive. Whereas if someone has just got synovitis, I can be a bit more like, okay, fine. I'll just give you a little bit of steroid, a bit of whatever, But if someone's got erosions, then, we've got so many new treatments now for rheumatoid and PSA. We can start to identify them. That's what I tend to do. I'll say, well, okay, this is an aggressive disease. I need to get you on the best possible drug for this. How do I do that? We obviously have to jump through different hoops, but I try to label my patients. And then it's also important for follow-up as well. It helps me time my follow-ups for these patients as well.
I guess the challenge with erosions, I'm going to play devil's advocate here and sit on the fence a bit, is that the challenge, I guess, is around erosions in a novice hands aren't always the most obvious, are they? And there's obviously lots of pitfalls and little notches in bone that are normal, and so you're looking for the presence of active synovitis alongside something that's pretty distinct in 2 planes, I'm guessing.
Yeah, absolutely. Yeah, usually.
Yeah,
you're right. I think, there are, a novice scanner will probably think that, kind of the notch around the MCPJ is probably an erosion. I get all the trainees saying to me, oh, this is an erosion, but, we say
that's why the training is important, I guess.
Yeah, absolutely. And when you've got, you've got other, sesamoid bones and things like that, and people think, oh, that's an erosion as well. But it's about sorts of scanning and just seeing, just trying to gain as much experience. And, that's the whole thing with ultrasound. It takes lots and lots of time, lots of practice.
Yeah. Nice question here. is say, how do you differentiate IPD, or I think DIP joint essentially involvement due to PSA or osteoarthritis? Are there any, I guess we mentioned earlier that there's a clinical context, but also are there any distinctive ultrasound features?
Yes, good question. I mean, so I probably didn't mention in my talk was that rheumatoid arthritis doesn't affect the DIPJs. If you have DIPJ involvement, it's usually PSA or OA. OA, the difference is that it doesn't cause any hyperemia. That would be the usual kind of, the difference. Now, if you look at DIPJ involvement, I kind of look at sort of, the nail bed as well. And if you have some enthesitis at the nail bed as well, that's usually indicative of PSA as well, because psoriatic arthritis affects your nails as well. So if you've got DIPJ involvement, you will, chances are you'll have some nail involvement as well.
Sure. And that's
so, and
feature,
and with osteoarthritis, you don't tend to get Doppler activity. Yeah.
And one of the other questions, Qasim, was around Doppler. This is always an interesting one. It's a difficult one to answer. I think from going back from my memory before I got booted out of the call was around how do you sort of optimize your Doppler essentially? Yeah. So that obviously we all know that Doppler has ample opportunity to be very excitable, but to also be a bit insensitive essentially to findings as well. Do you have any top tips about that from your perspective?
I mean, I mean, I'm quite harsh with Doppler, if I'm honest with you, in the sense that it takes a lot for me to call Doppler. I'm more of a skeptic around Doppler activity. So what I tend to do, because I know that, I think a radiologist once said to me, he said, look, you've got so many digital vessels, how do you know it's not artifact? And, I suppose the general
we're losing you a little bit.
Yeah. Can you hear me now?
Yeah, that's a bit better. Yeah.
So the general principles are really to, lots of gel, get a massive kind of area as well. So you're picking up, the entire sort of area. So if it's the joint you're looking at, you're starting, from the gel skin all the way down. And in terms of, the settings, it's really, when you think about rheumatoid PSA, etc., it's usually slow flow. So it's not high flow. So you've really got to turn sort of the PRF right down. And I tend to increase the frequency up to see a lot of noise, and then really sort of, reduce it, and just to see whether there is any activity. And I think a lot of it is practice, and you've got to find a way that works for you. So I think it's a lot easier to do that, when you're actually showing someone, on a machine, rather than, sort of verbally, give an answer. It is really difficult, but I think, increasing the frequency I've found is helpful, and then slowly sort of reduce it down. That usually eliminates a lot of the artifacts, and just make sure that your settings are completely optimized. Some of these new machines have obviously got, PRF, everything's usually adjusted for you as well. The other thing is about probes as well. Usually use the high frequency probe. So if you're looking for Doppler activity at kind of the peripheral joints, the PIP, DIPs, etc., use the hockey stick probe rather than the big probe.
Yeah, I think the other thing I often recommend when I get asked these questions is about saying, it's being quite reflective. So if you have a patient who has got active synovitis, then really sort of go to town in that situation. Really practice your Doppler on that active joint, so that you actually know that what it's picking up, and that it actually is picking up correctly, and then remembering your presets as part of that, so that so you've got that to sort of benchmark against in the future, essentially, as well.
I mean, it's quite helpful. I mean, the Doppler settings for, say, something like GCA slightly different as well. And that gives you a bit of an insight, really, you know, the differences, you know, between the two.
Yeah. Two last quick questions, Cass, and then we'll let you go and have a rest on your Monday evening. Is an enthesophyte an osteophyte in a different place?
Yes. An enthesophyte is usually at the site of the enthesis. An osteophyte can be within the joint.
And then how thick does the double contour sign need to be?
Yeah, there's no hard and fast rules, really. It's just whether you kind of see that double tram line type sign.
I guess my little point about the double contour is the pitfall around that one is just be careful if it, you know, obviously you can get sort of cartilage interface sign around tendon tears and things and give you that kind of appearance as well. So Andrew, just a little extra thing for you just to be mindful of there if you're scanning shoulders and stuff like that. Guys, I think we're probably pretty much out of time. Hopefully that's been really helpful.
All the questions, yeah, is everyone? I mean, I'm happy. Any other questions? If you email me or, you know, please do.
Yeah, absolutely. Please reach out. If there's a desire for us to do any sort of further sessions like this, I'm sure Qasim would be happy to if I twist his arm hard enough.
Yeah, absolutely. Yeah, I mean, you know, just talking about rheumatological disease for, you know, for people, you know, that may not see lots of rheumatology, I'm happy to kind of do a brief overview. And I think that probably, you know, some of this will make more sense, I think, when you know, when you've got that as well. I'm happy to do that.
Yeah, absolutely. So guys, this has all been recorded. I'll wait to see what happens to the bit where I sort of disappeared and then came back. We'll have a look. Hopefully it'll all go on the website, so you'll be able to access it after the talk, and I'll send an email out to everybody who's registered, so that you'll get a full link to the recording. Thank you so much to Qasim for your time this evening and your enthusiasm. I said earlier, it's great. It's really fantastic to work with people who are enthusiastic about a topic like I am, and enjoy seeing the impact that ultrasound makes for patients' journeys and things. So
we're a bit crazy, aren't we, Stu?
We are, but long may it continue. And yeah, if you want to have a look at what we do from the ultrasound point of view, please do check out our website. I'll put the link in the chat box now, but I'm sure most of you are familiar with it anyway. And if you've got any questions or queries, then please do feel free to email me at the ultrasound site through the contact forms on the website or whatever, or via social media. So thanks for coming this evening and joining in for your questions. Please enjoy the rest of your evening, and hopefully we'll have some more sort of evenings like this planned in the near future. Thanks very much, guys.
Thank you, Stuart. Thanks, Qasim. Thank you very much indeed.
You're very welcome.
No problem. Cheers, guys. Bye for now.